these few words. Now let's start with the first session. So this is the session on prostate cancer. You already know the two articles that we are going to. If you have spent time to read them again, of course you must have read them because it's very important for day-to-day management, but I hope that we can have a more intense academic discussion. And for this prostate cancer session, our chairperson is Dr. Rangaraju. Dr. Ranga, please come over. Thank you very much. May I request you to please, address us for a few minutes and let us have your thoughts.
About the topic? About the topic, right. Okay. Thank you very much. I think it's been a proud privilege to be here today and amongst the the gems of the medical oncology people. Thanks Purvish, thanks Amish, and nice to see all the old friends over here. I think my session is going to be on the prostate. And so the prostate today is a medical, the castration-sensitive prostate cancer. So we're going to talk about that. We have two papers followed by a panel discussion. So all I want to say is all of you have been definitely treated, and we have seen over the years a lot of change of treatment which has happened. Where earlier we were just giving the hormonal treatment, this followed by the addition of the chemotherapy with the Docetaxel. Then came the Abiraterone, then came the Darolutamide, and then came many other molecules, including the Darolutamide, which is now coming, and made a big change in the whole thing. So triplet therapy is something more which is to be done. So while we're doing the treatment, I think we need to remember 2-3 things. Number one, that we need to have a depth of response. That means decrease the load to a maximum possible. That's, I think, the most important thing. And at the same time, we have to ensure that it has to remain for a long time, the duration of the response, so that the chemotherapy or the rather castration-resistant phenomena which happens naturally in all these patients can be delayed as much as possible. So that's the whole aim. And then give them the triplet therapy, continue with this. At the same time, we have to really personalize the therapy. Personalize the therapy according to the volume of the disease. And then now markers are also coming in, patient general condition, patient age, whatever the comorbidities he has. So I think we have to really personalize. So today we are in a different era where we have a lot of choices, lot of choices, and we have to specifically design the treatment for a given particular patient. So I think things have changed, very, very exciting times. So we can start the whole session anytime.
Thank you very much for setting the ball rolling for the prostate cancer session. Now may I invite Dr. Ghanshyam Biswas as the moderator for this first session, and the panelists for these two publications are Dr. Soumya Surat Panda from Bhubaneswar, Dr. Nikhil Gadial Patil from Hyderabad, and he is organizing the next ICON, the Golden Jubilee ICON conference. Dr. Amol Akade, I think he needs no introduction. He is the Twitter or X expert for us. Dr. Asif Sheikh from Ahmedabad. Dr. Lalit Mohan Sharma, whom I met last many days ago, that is yesterday. And Dr. Rajit Chanana. Please come.
Thank you so much. So Dr. Lalit is my roommate. So wow. if you wouldn't given me a room, so probably next 6 months in DM I have to stay outside. So thankfully Dr. Lalit. So he's my first oncologist and also a roommate. So lots happening in the prostate cancer area, and you get to learn from Amol's daily tweets. So already Dr. Rangaraju sir has set the ball rolling. Now the moderation and expert comments by Dr. Vineet Talwar. We'll start from the iconic 50th icon person. So out of 100 prostate cancer patients, you treat, so how many of this category will fall into a metastatic CSPC, non-metastatic CRPC. So non-metastatic CRPC is gaining importance because of the drug approvals, and then metastatic CRPC. Just a rough estimate.
So most of the patients still are hormone-sensitive prostate cancers, metastatic. NMCRPs are very, I wouldn't say one handful, very, very few patients. And again, as you understand, it's a continuum. So most of the patients eventually will turn into MCRPCs. But I would say around 60% still be hormone naive.
So Soumya, so with whom I work on daily basis in the medical college. So what are the common comorbidities associated with prostate cancer?
Yeah, so most of the patients, they are elderly patients, and if you see the median in the trials also, it is something like around 65 to 70. So most of them are on polypharmacy. They are hypertensive and diabetics, and it is very, and they are also osteoporotic. So most of the patients that do require multiple medications along with the prostate cancer tablet.
So have you started doing a DEXA scan in all prostate cancer patients?
Probably when the patient is having some pain, and at that point I do that, but not routinely I must acknowledge that.
So what about, because India being a hub of diabetes and either Docetaxel or Abiraterone steroids?
Yeah, so that is routinely done. So all the patients that come to the clinic, they are screened for the diabetes and hypertension. So of course we do look at them, and also your treatment carries steroids often. So that's why we do routinely check for the sugar levels.
So the tweet man Amol. So what is the regular dosing of a steroids, so prednisone in a hormone-sensitive and then CRPC setting?
So generally the standard is between 5 mg BD, and we start with that and then modify if required as per the diabetes status. In my practice, I generally involve a physician to take care of the diabetes. I do not rely on my own expertise as diabetes expert.
So basically, we are all physicians. Then we
but I still involve somebody who is actively looking into diabetes. So I'm flexible with the steroid dose.
And what about in CRPC? The same dose? Or?
Means to begin with, I stand with the standard dose, but later on I try to taper it off. If I give more preference to the control of sugars rather than the exact dose of steroids.
So can I add to the previous
please.
Like about the doses, 10 milligram is the dose which we start 5 milligram BID. If the diabetic status worsens, then we take help from the treating physician or the treating endocrinologist. Other important point, one more, other than whatever has been discussed, the social support, like many times the elderly person comes alone and they don't have the support. So before taking the treatment decisions, we need to keep that part also into consideration, that what sort of support they are having.
So other point that I want to raise is that, see, that dose is for the full dose of Abiraterone. If you are giving low dose of Abiraterone with meal, then you may get away with the lesser dose of steroids.
Senthil is there, so who has
Yeah.
already published that. So Lalit sir, so what is the median age of presentation of your prostate cancer patients? Because we'll see in both the trials and now, so just an average.
So we see in their 60s, in fact, early or late 60s.
Do you see at 70s, 80s, 90s?
Yes.
I have a patient at 90 and 100 also.
Yes, we have seen up to
99.
90s, not in 100, but we have seen most of them are in their 60s.
So do we see any younger age group today, in like all other solid tumors? So 10 years earlier, so prostate cancer is also the same? No.
Not very high, but yes, we are seeing in their 40s and 50s also, but the proportion is not that high.
So coming to Rashid, now, so moving into, because the whole discussion is on metastatic castration-sensitive prostate cancer. So before we go into the trial, so these are important. So high volume disease versus low volume disease. So how do you define and how it has come into picture?
So according to Charter trial, high volume disease means visceral metastasis or for more bone metastasis that should involve one beyond vertebral or pelvic mats.
So Nikhil, so what are the high risk disease?
So again, high risk disease basically again from the charted criteria is Gleason score 8 or more. In addition, bone metastasis which are 3 or more, and visceral disease. So
That actually came from the latitude. Yeah. So yes, Soumya, so is there a difference between a synchronous and a metachronous metastasis?
Yeah, it does make a difference. We have seen synchronous high volume, synchronous low volume, metachronous high volume, and metachronous low volume. So patients presenting with a de novo metastasis and somebody who has been treated and then presenting with the metastasis. So somebody who is treated and then presenting with the metastasis, they do have a longer overall survival, and they are a little bit biologically, a little bit more, you can tell, more indolent. But somebody who is presenting upfront, then their survival is a bit low, maybe due to the lag period of from the diagnosis. But yes, they do have a difference in the trials, and even clinical trials, you can see the PS1 and the Arasens, they do have difference in the population of synchronous. So PS1 didn't take into account the synchronous one.
So that is the important point, that most of the trials have de novo metastatic patient, not the one who are previously treated and then came back with the metastasis. So that is very important. Such patients are underrepresented in the trial. Other point with this particular classification is that, this was discussed in one of our WhatsApp groups also, that what if somebody has a florid skeletal mets in the entire vertebra and nothing outside?
Super scan.
So what about those patients? So probably this definitions needs to be taken into account, individualized, rather than taking sacrosanct. But what it means is that if it had gone beyond the usual spread, which is the surrounding lymph nodes and the pelvic bones.
It is seen in a prostate cancer patient.
Yeah.
So I'm also, so what is the volume of high volume disease, means what is the percentage?
So in my practice, if I go by stricter definition of high volume disease, I will say around 20-25% do have high volume in whatever patient that I see.
And what about high risk patient population?
Again, the same numbers. Because most of the patients probably which I get are low risk and low volume.
High volume and high risk correlate?
They overlap. They overlap.
So there is an overlap, but there is something like in the trials 7 to 10% difference is there.
Can I just, please. Yeah, so there has been a study regarding high volume and high risk. So how much is the concordance? So usually it is around 80% their concordance,
right.
So around 20%.
So around 80%, right. So high volume disease, as said by Dr. Asif, and high risk disease, so one came from chartered, one came from latitude. So de novo metastatic, what Soumya pointed out, so that is synchronous, first diagnosis with metastasis versus somebody who has metastasis after a local radiotherapy. So percentage, we have already discussed the percentage of high volume. The treatment landscape for metastatic hormone-sensitive prostate cancer has evolved from 2015 from the charted and the stampede to what is the Arasens. So there is a paradigm shift in the treatment. So we considered only ADT, then ADT plus Docetaxel, then ADT plus so the Abiraterone, then Darolutamide, then Abiraterone, then came PS1 and the Arasens. So these are all drugs. So 9 types of therapy. Asif, so
the majority of the discussion today is going to be on HSPs.
right.
Like in breast cancer, we have primary hormone refractory. Similarly, any of us have seen CRPC at presentation. And this adds on to what you are saying. In Delhi, I was talking to a few of the colleagues. The younger prostate cancer, they are relapsing very fast on ADT plus, Abiraterone acetate or whichever. Dr. Rangaraju sir is also nodding his head. So, do we have a definition? I am not aware that there is any definition in prostate cancer where within 6 months or 1 year, if the patient goes to CRPC, it is called as ADT refractory disease.
We do see such patients who doesn't respond to any first line therapy. And we have seen in lung cancers, so they are known as fast progressors. At the end of 4 cycles of platinum combinations, they don't respond. Then probably you choose out a regimen of anti-VEGF. So I don't know if there are definitions.
Just a comment. So there was a paper from TMH by Amit sir. Again, they had defined a young prostate cancer, and they had taken a cutoff of age of 45, and they had taken that patients that they are very aggressive. So of course we will rule out the small cell histology and the NEC, but definitely there is a paper on that area, that young prostate cancers that do behave aggressively.
As far as my practice is concerned down south, we see more of younger patients around 50 plus. That's a thing, not on 70, 80 as what you see in the charter, and then more of a high volume disease, extensive metastasis. That's what the medical oncologist will come to contact with rather than the uro-oncologist. So what I see in my practice is high volume disease, extensive metastasis involving the nodal metastasis, visceral metastasis, as well as multiple bone mets, and younger age 50 to 60. And the biology differs, as I was talking about. The younger the patient, more aggressive disease at that presentation, they have a different biology. They may have a more aggressive when compared to a more indolent disease, what the Western people are seeing, where they see progression from locally advanced to a single metastasis to a oligometastasis to a multiple metastasis at the end of the journey. What we see is the other way around.
There are some biomarkers which are being tested, P53 mutation or SHOP mutation, and based upon that, they are tried to segregate.
Yeah, but
those are aggressive,
not in
non-aggressive.
practice or probably
Yeah, not yet standardized.
Right. So now, Asif, so percentage of patients still you consider only ADT. So it can be an elderly patient, frail patient, percentage of patients in doublet, and percentage of patients started putting into a triplet. So as of 2024.
Sir, if patient is not fit for doublet therapy, then only single agent therapy. Frail not fit for Abiraterone acetate because of hypertension, diabetes or elderly problems. Most of the patients are doublets, and from 1 year, if patient is high volume, then probably triplet.
So Lalit sir, so now percentage of patient on agonist, because ADT is mandatory. So 1966, 2024, so ADT is compulsory. So percentage of patient on agonist, percentage of patient on antagonist, and now we have the oral antagonist launched by Zydus also. So now many of us will prefer, because at the 7,000 rupees cost, much cheaper than the injectables. I know that subsequent time we'll see more patients into an oral also. And percentage of patients post-surgical orchidectomy. And because many patients come to surgeon, general surgeon, urologist, even the unfortunate part, even in a early stage disease, curative intent, they come with a orchidectomy.
So in fact, the last one we see more often 70-80%, because we see more patients coming from the rural background. So most of them, they undergo the castration, in fact surgical castration, before coming to us. So that remains the topmost.
And what percentage of antagonist? So
Not
do you
much
prefer in any setting?
Not yet, in fact.
So Nikhil?
Our percentage of use of antagonists is definitely on the rise. Again, these are those typical patients with the spinal meds with the impending cord compression, where we definitely would like to use. But again, the cost, the compliance, there are many issues involved in that. And we have, of course, if you really ask me the percentage, most of the patients still are on GnRH agonist. There are certain around.
Agonist predominates, even in the trial also, agonist predominates, followed by, but they have probably because most of these patients are from the Western world, so less than 5% actually had a surgical castration. So Somyo, now prostate cancer is a different disease. We are talking about metastatic hormone-sensitive prostate cancer. The endpoints are different. So how do you look at the endpoints? What are the usual primary endpoints and what are the secondary endpoints? So we talk about especially in a prostate cancer.
So in prostate cancer, earlier most of the trials, if we look, then OS was the primary endpoint, but of late radiographic PFS has come into picture. So radiographic PFS and OS is becoming a co-primary endpoint. And so if we look at the secondary endpoints, then mostly it is time to CRPC, time to skeletal SSC, and time to pain. So those are the in the secondary endpoints, but mostly the primary endpoint has shifted from OS to a radiographic PFS.
So we are adding more and more drug. So one of the important is that, so besides the PFS and the OS, the importance is that how long you can put the patient away from a CRPC setting, and rest are definitely important.
Just one comment before that, the oral tablet, the Relugolix is still, it is not approved in the CRPC.
No, we are talking about hormone sensitive.
Yeah, so the oral list.
Just a comment about that primary endpoints. Ideally, it should be OS. In fact, prostate cancer is one of the few trials in which, from the time of the NTANOC, which meaning got Docetaxel for the castration-resistant prostate cancer, the OS was a standard endpoint. This radiographic progression-free survival, unfortunately, depends upon the definition of when are you going to do the radiograph, how frequently that imaging has been done. So I still feel that the OS should be
So
considered.
all your patients are on a PSMA, or you still go for CT scan and a bone imaging?
No, I generally prefer PSMA. But from a trial point of view, this RPFS has a lot of issues, and as a clinician, probably will be happier if we have OS as an endpoint.
Yes.
So correct. In the clinical practice, to really have this RPFS routinely applied to patients is a big challenge. One is, of course, what Amol just now mentioned about how frequently. More importantly, we are doing a lot of PSMA scans. So how to really interpret this data in the era of PSMA also probably, I am sure we are going to discuss it.
So now, so Dr. Lalit, so what is your preferred treatment, first line treatment for a metastatic CSPC in the doublet era? So ADT plus docetaxel came from Charted and Stampede, then Abiraterone came from Latitude and Stampede, enzalutamide from Enjamet and Arches, apalutamide from Titan, and darolutamide is in a bay because I was a part of the Aronet trial. So all darolutamide for 5 trials starts with A. So darolutamide in a bay, so maybe this year end, so we'll have a data. If that comes positive, then again, so you have 5 choices. So how do you choose?
So in fact, the real clinical practice, Abiraterone is the most common partner with the ADT. The reason is, one is it is simpler to take oral medication, no admission. Second is it is approved
So
by
it looks
the...
simpler, but with toxicity.
Yeah, but second important is like this is available in the government free scheme to us. So this is the most preferred.
Yeah, so all these trials have been put on here. So now you have the oral drugs, radiotherapy, docetaxel. So how do you choose your ADT partner? So Nikhil.
So currently we are talking about a doublet part of it, is that correct? So again, first of course we have mentioned about the survival part of it, and secondly the volume, disease volume. Patients with the high volume, I would prefer going more for, if you are only talking about doublet, not about triplet, more to go with the docetaxel. And high versus low, again, if the patients, again, performance status and so on and so forth, will take a call about use of chemotherapy. As we know, Abiraterone has both high volume as well as low volume has shown survival benefit. So that remains an option for irrespective of the volume.
The patient concerns, the biological age, the comorbidities, fitness for a chemotherapy and suitability of a corticosteroid. So this can be put into disease factors, clinical factors and the drug factors. Sorry. So in the past, in the Charted and the Stampede era, so what are the number of cycles of docetaxel? What is the dosing of the cycles of docetaxel?
Yeah, so docetaxel, the benefit of that is that it is time limited. So you give 6 cycles and then you can stop. Unlike Abiraterone and enzalutamide, which you have to continue till progression.
So 2 weekly, 3
so
weekly, 50
3 weekly,
70
70 milligram per meter square is the dose which we use, and it is 6 cycles.
So right. So in those eras, so we chose Abiraterone for you can use in both, so low volume disease, but again somebody docetaxel, if somebody wanted a limited amount of treatment, probably that was the reason. So what are the challenges with Abiraterone plus prednisone in this setting? Lalit sir.
I think one important is compliance, and second the toxicities, especially the edema and the
So
liver
hypertension,
dysfunction.
hypokalemia, I think everybody has rising of SGOT, SGPT and some probably increase in cardiac incidence. So they require frequent monitoring. Yes. And especially worsening of diabetes, hypertension. And now people are looking at the long term because now this drug is there for more than a decade now with regards to increased cardiovascular risk, glucose intolerance, osteoporosis and osteopenia. So these are all clinical factors that has to be considered.
Can I add one point? So it has been shown that if patient has used Abiraterone first and if it has progressed and then you use enzalutamide, then likelihood that the enzalutamide will work still is bet more as compared to first you have given enza followed by Abiraterone. And hence,
so that comes
by
in the
all
sequencing.
logic means that you should use Abiraterone as the first partner if it is feasible.
So some key words about the Abiraterone, so rightly most of us are using because in the available in the government. So enzalutamide also comes with toxicity, especially somebody had a seizure. Apalutamide looks to be the most eligible bachelor among this. So darolutamide much beyond the reach because of the cost. So now what percentage of patients, so Lalit sir now, so Rajasthan government gives free now, so everything. So now, so how many patients, eligible patients will put into triplet? So either PIS1 or the Arasens.
In fact, both the PIS1 will be probably yet the preferred.
Okay, good. So there was another trial in the triplet which was Enjamet, but that was with enzalutamide, but that was a negative trial. So as of now, we are with Abiraterone and darolutamide. So Nikhil, sir, rationale for triplet therapy?
So the main rationale what I understand is in the earlier part of the treatment, the patient's performance rate is also better, the handling is better. In addition, the resistance patterns, there is a bit of a synergy which happens between both Docetaxel as well as Abiraterone without any additive toxicity, what has been shown in the various clinical trials. So especially when you get a benefit, when you addition of triplet, when you get a survival benefit, in addition, maybe letter resistance, the time to CRPC is also prolonging without any significant additional adverse effect is something
Right.
what is.
So more favorable disease biology, less acquired treatment resistance, except what Dr. Amish said. So and therefore demonstrates a more durable treatment responses. So the treatment in this setting can often be better tolerated. So given there are few cumulative toxicities of prior regimens and as well as fewer symptoms and lower disease burden prior to disease progression. So this was what we are discussing about the piece 1, 2 into 2. And the co-primary endpoint here was radiography PFS and OS. This was a 2 into 2 factorial. And these are all key secondary endpoints. So now, Amol, so you look at this age. So because since most of these patients were not from Asians, so 66, don't you think they were young age because the range between the age was 60 to 70 years. So fitter patients were taken?
Technically, yes, but if you see current ASCO GU23, they have done a subset analysis of those patients of piece 1 above 70 age, and they have presented that data also in the last ASCO GU 2 weeks back, and in which they have shown that those above 70 who are fit to take docetaxel still get benefited by triplet, but those who are not fit to take docetaxel, benefit of triplet is less. So they have done the subset analysis and they have presented in ASCO GU.
Now you look into the low volume and high volume. So you said 20-30% of high volume, but in the trial you see around 60%, 2/3 of the patients were actually high volume.
But if you see the further analysis and which they have given, amongst that high volume, how many were there with the visceral mets, which we are worried, liver metastasis or organ metastasis, only 10 to 12%. So
Soumya, so if you look at the median PSA, which is 13.7, so do you really see such a median PSA in your practice? Or it's low?
It's a bit low. Most of the patients that we see, they are more than 100. So yeah, the median age looks a bit low, the median PSA looks a bit low, but that's how the data is.
Yeah, so in the radiologic PFS, so you can see, so there is a starking difference. So 4.5 versus 2 years, almost 2.5 years survival advantage. Coming to this group also, high volume versus low volume. So both groups are benefited. So definitely high volume overall population versus the other group again. So there is an advantage where you can see an OS reaching up to 6 years, 5.7 years in favor of the triplet. So this is the OS. So any comments, Amol?
Comment about the overall trial, and I was just telling Viraj that this is probably one of the best designed trial and whatever that are presenting today, henceforth the trial designing issues will further go down. So piece 1 is appropriately kept as the first trial.
So there is no scope of improvement in this trial?
No, so there is a scope of improvement, but if you compare the subsequent trials that will be discussed with other diseases, then you will realize that piece 1 was much better. They had amended the trial protocols from time to time with whatever the newer therapies which were approved. They tried to keep the trial statistics in check by appropriately giving those many number of patients in each arm. So piece 1 is a reasonably good trial. Of course, there is issues. If you see retrospectively, now they have presented their low volume data with RT, and again ASCO GU, they found that those patients were less in numbers. So retrospectively, if you look, probably for all those 4 arms, probably they will require more patients rather than 300 patients. But still, that I feel piece 1 is reasonably good trial
so
and appropriately first.
Ghanshyam, yeah. There are 1:1:1:1:1. There are 4 arms in piece 1 trial. And if you see Arasens as he would present, there are just 2 arms, 1:1 randomization. You add radiotherapy, you don't add radiotherapy, you add chemotherapy, you add Abiraterone acetate, you don't add. You really think that piece 1 was a very simple, straightforward and a very good design trial?
Absolutely. What the important point that they don't answer is what is the advantage of adding docetaxel to the triplet, which is the retrospective thought, which is correct. Yes. But if you compare with the next trial, then also if you see that probably PS1 has done a better job than the subsequent trial.
Actually, the biggest criticism of PS1 trial was that there was no Abiraterone alone arm. Now, why should you make the standard of care as Docetaxel plus ADT? It should have been
Vineet sir, we
ADT
have kept
plus...
your expert comments at the end.
No, this is with the reference to context.
Yeah, because what happened, the evidence came in that sequence.
The biggest criticism was there was no Abiraterone law.
So Lalit sir, now see in the types of castration. So you said 70% from your village patient. So yes, surgical castrations hardly in a single digit number.
Yeah, very true.
Okay. So Rashid now, so high volume versus low volume. So are you happy with the OS?
Yes, so in high volume disease, there was OS advantage. In low volume, there is still not separating of very well.
So what is your take on the toxicity? Now you are adding more and more drugs. Yesterdays we are frightened of giving a docetaxel. So that's why 75 se 50 ho gaya now. So with triplet, so how comfortable you are?
So giving docetaxel and abiraterone acetate is not easy because abiraterone acetate has toxicities and mainly hypertension and transaminitis and some cardiac toxicities. So 11% more grade 3 and grade 4 toxicities were there with abiraterone acetate.
So to simply understand, so with the triplet in the PS1, 3H. So hepatic enzymes involvement, so hypertension and hypokalemia, these were significant as compared to the comparator arm. So now, Soumya, so now beyond progression, so if you see, so what are you going to do in a triplet setting?
Mostly, if the patient has not been exposed to chemotherapy, they will expose to chemotherapy, and if the patient has been exposed to Abiraterone, then they will mostly be exposed to Darolutamide, and that was done in the trial also. But as sir mentioned, there was no another hormone, novel hormone, be it Abiraterone, be it Darolutamide, be it Darolutamide, so be it the another hormone.
So in the triplet arm, most of these patients received actually cabazitaxel,
yes,
whereas in the standard of care, most of the patients received Abiraterone followed by cabazitaxel.
So that is one of the criticism of the trial, the post-protocol therapy for the PS1.
So 17 minutes.
Just keep a watch on.
Right. So the PS1 conclusion, we are happy with the, so Amol, so final comments. We are happy with the results as of now?
See, it is reasonably good trial. There are issues, of course, with the trial. The only question as was discussed was, what is the advantage of adding docetaxel? And if you see again this ASCO-GU, there was a poster presented of the real-world evidence from US in which they have shown that what is the indirect comparison of ADT plus Abiraterone versus ADT plus docetaxel in a triplet setting. And they have shown that there is no added advantage technically of docetaxel, especially if it is not very high volume disease. So I will restrict triplet to the high volume disease and a fit patient. But trial is overall okay for me.
So Soumya, so now, so we are good to go with the triplet. So with our patients with a poor nutritional status, being a diabetic, poor compliance. So each piece going to be a piece for you or going to be into pieces. So taking into efficacy, tolerability and less than 70 versus more than 70 years.
So it will be pieces for somebody with an elderly and a low volume, but it will be peaceful for somebody who is a young and having a high volume disease. We cannot ignore the 1.5 year gain that was seen in the high volume disease. So somebody who is a fit and young, be it AUA guidelines, be it ESMO, they have all taken into account that particular part that this triplet can be offered to them who are having a high volume and they are young and fit.
So this was a post-hoc analysis which was presented in the 2023 ASCO-GU. So more than 70 years derive a lower benefit both in terms of radiography PFS and OS from adding to the standard of care.
Another point that I just wanted to add is that if you are worried about the toxicity, there is a study or data shown that 7 to 8 months of PSA level should be taken into consideration, and if it is less than 2 nanogram per ml at the end of 7 to 8 months, one can consider de-escalation. Of course, there is no prospective data, but retrospective data and analysis of most of the trials have shown that is the time period when you can take a call that where you can probably slightly de-escalate.
So Asif, are you happy with the trial design of Arasens? So any points to be noted here?
Sir, one disappointment with Arasens for me is that subgroup analysis was post-hoc analysis. So, the numbers in low risk and low volume were very low. So, sample was under represented in the trial. That was the only concern, and that is the biggest concern because on the basis of that only they designed everything.
So, what is your take on Docetaxel 75 milligram per meter square on day 1 for 6 cycle, 28 days cycle? So, whereas this 28 days come, so we knew our weekly, we knew our 2 weekly, 3 weekly. So, any regimen exists with the Docetaxel of 4 weekly?
So yes, that is another thing because we used to give 3 weekly only.
Another point is about the synchronous versus metachronous. The number of patients with the metachronous, which are again a good subset patients, were slightly low in this trial, and as compared to the previous piece, which only had de novo, that was again a cardinal difference. About the trial, I think again it's a very well designed trial. The way I looked at it. Yes, but one can always. About this, he talked about the piece. I'm talking about the Arasens. I already made peace with Amol. So, but Arasens also is a very well designed trial. But
if you go to the first slide, if you just for a second, if you see there are 286 sites and 23 countries, and I think around 3-4 years they could recruit 1,305 patients. They probably with 286 sites they could have done much better than what they have done.
Absolutely.
They have probably taken 1 patient per site per month maybe or lesser than that. Very selective.
Right, absolutely. So Soumya, now do you really mention about M1A? So we are discussing about a metastatic HSPC. So M1A, M1B or M1C. So do you really in practice you do?
So mostly in practice we see the skeletal fraction and the sites that are involved and whether there is visceral metastasis or not. So as a whole we see the patients. We usually don't classify and stratify them as M1A, M1B and M1C.
So, I don't know. So M1A is a non-regional lymph node metastasis. So in that trial you can see there are hardly any representations. So M1B is bone plus minus lymph nodes and M1C is a visceral plus minus lymph node or bone. So we have discussed about the Docetaxel use. So this looks, I don't know, so how they got an approval of a 28 days. So putting the evidence into a real world practice. So whether all 3 drugs needs to be given concurrently, Asif?
So if we are talking about Darolutamide, I am okay with that. If you are talking about Abiraterone acetate and enzalutamide, I am not okay with that.
Enzalutamide is out of question.
Yeah, so the only concern is safety. And Darolutamide safety profile is very good because there is no drug-drug interaction with the Docetaxel. So there was no added toxicity.
So it also remains unclear whether all 3 drugs, because I have seen some important KOLs in the country who have started with chemotherapy and adding Abiraterone in the next cycle. So it's unclear whether all 3 drugs needs to be given concurrently or so you can start the oral drug can be started before or after Docetaxel. Any validated predictive biomarkers what Amol was putting. So as of now, probably it lacks in the clinical practice. So this is what the Arasens baseline characteristics looks like. So high volume versus low volume, then high risk versus low risk. So again, OS by disease volume. So Nikhil, any comment on this?
Again, with the high volume, high risk as well as low risk, there has been a benefit except for the low volume. There seems to be a benefit, but it has still not reached the statistical significance. So technically in all, I would say, subgroups, which is again post-hoc analysis, there has been a benefit of addition of darolutamide, but the significance is not established in the low.
If you go to this one slide back, if you see the low volume, the hazard ratio is crossing 1. It is not just not beneficial, probably slightly detrimental also.
Absolutely. So what about, so since you're at the mic?
No, there seems to be some benefit over there, but it is not reaching statistics.
Amol, can you explain? There's a new statistics you are teaching. How initial years, we are looking at the median follow-up. We are looking at the statistics.
Now, that's what I'm saying. So first of all, this is, I think, almost close to 4-year follow-up.
If you see the crossing.
And if you see the confidence interval, it is ranging from 0.41 to 1.13.
It is crossing the line of unity, but if you see the difference in the end, at the end of follow-up, I think, and you see the hazard ratio, it still is less than high volume, but still showing significance.
When it crosses unity, there is some signal that's probably harmful.
It doesn't mean it is harmful. It probably it tells you that it is not
detrimental. That is
statistically
what I'm trying to
significant.
say.
Yeah.
So the events have not yet occurred. So low volume will again, the figures will change as the time progresses. So in high volume and high risk, we are definitely seeing that is because of the number of events that are there.
Soumya, so since we are talking about the time to CRPC, so your comment on this?
This is the pathophysiology overall, that what it looks to me. So we are delaying the time to the CRPC, and that's why the graphs
So
are very
that's
clear.
important. That's the most important. Though it is a secondary endpoint, probably this is what we are looking at. So the other endpoints we have discussed. So do you look at, so Lalit sir, so do you really look at pain progression and the first skeletal events? Definitely we look into that, and worsening of symptoms. So are these into a clinical practice?
So every time, in fact, we check for the pain and the symptomatic relief.
So we do a PSA 3 monthly, 4 monthly, then 6 monthly PSMA.
No, that is okay, but at least from the clinical point of view, we always assess whatever the symptomatology has been and whatever the improvement has been.
So the Arasens conclusion, so Nikhil.
I think again a very well designed trial, and again the triplets has shown to be beneficial. Of course, now we basically discuss more about the post hoc analysis, but here also in the various subgroups, I would say low versus high risk especially, there has been definite benefit. CRPC, what we just now discussed, is quite an important endpoint even in our clinical practice, more so for our patients, because patients also don't want to be in a more of a CRPC part rather than when they are sensitive part. So after a thorough discussion, so I think this probably is quite important for patient standpoint of view also. Unfortunately, the drug currently is not available. Very much manageable toxicity also.
So now we have 3 triplet trials. So one of them is negative with enzalutamide. So they will again come back with some more designs probably. And so triplet versus doublet in this setting. So there is an updated network meta-analysis by disease volume. So that they conclude that ADT alone no longer represents a valid treatment option for a metastatic CSPC. Though I was a part of Aronet trial, so where darolutamide was in the first line setting, so one of the arm was only an ADT, and that's the reason many of the institute PI did not participate in that. Similar considerations applied to the doublet therapy with docetaxel plus ADT for low volume metastatic CSPC in comparison to ADT. The benefit of combination therapies other than the combination was not substantial. For high volume metastatic CSPC, darolutamide plus docetaxel, that is Arasens, plus ADT ranked first, followed by the PIS1, and then the combination of Abiraterone and ADT combination therapies. So putting evidence into a real world practice, so the addition of docetaxel will lead more careful considerations, as Amol was hinting to, so including disease factors, so metaconus versus synchronous, the volume of disease, risk category, the presence of visceral disease, histological and molecular risk factors, which is still under consideration. So there are other patient factors. So the proposed algorithm can be like this. So Amol, so do you agree to this? So any scope for improvement here? This looks simpler at this moment.
What is going to happen in future is the question going to come to whom
So
are we?
February 2024.
As of now, this looks okay.
Right. So newly diagnosed metastatic CSPC, high volume synchronous, so docetaxel should be there. Low volume synchronous ADT plus ARPI. High volume metaconus, again, so docetaxel should be there. Low volume metaconus ADT plus PRI. So this was a meta-analysis. High volume synchronous at de novo. So clear benefit with docetaxel. Low volume metaconus, no benefit with the docetaxel. So this is our friend in need NCCN, so which we look into. So these are already in the guidelines. And so this.
So can I add a point?
Please.
What is going to happen, and probably the next question that will be answered is that, what is the role of quadruplet? That means for high risk, what is the role of local RT? So it is going to go ahead.
Are you going to add BMT also?
No. This is PIS1 has one arm, the local RT. So that is what is going to. Why medical oncology should have all fun? Why not radiation oncologist also?
But they are not considering as a, because in the PIS1, so actually there are patients who are getting 4 treatments. So
the next question will come that for high volume, is it there an advantage of adding radiation? They have shown in the low volume that addition of RT is beneficial. So what about, so quadruplet versus triplet is the next question that probably we'll discuss in the next OBTO, probably next year.
So the treatment options in a prostate cancers has really snowballed. So a long hiatus for more than a decade, and now suddenly you see, so all treatments coming into place. So the piece after the piece one, so instead of talking 3 years or less, so we are talking about more than 5 years in a metastatic non-curative setting. So that has what the triplet has brought into picture. So the triplet, a better efficacy safety ratio compared to the sequential use. So in the combination, in the doublet is used for a metastatic CSPC, then docetaxel will be used anyway for the CRPC setting. So why not use it earlier with more efficacy and a similar toxicities? 6 cycles of docetaxel at a 3 weekly 75 milligram should be the way, because 28 days is not the practice. So definitely with the growth factors. So final comments from Nikhil. So practice changing, any concerns, agree for both Abira and Darolutamide?
Definitely practice changing, not for all patients. You have to select out the patient. You already shown a nice algorithm for high volume patients. Probably we would reserve the triplets more often than not. Low volume patients, probably we might still be okay, you giving a doublet. Concerns, a bit of a toxicity, that 10% what we are looking at 3H, what you mentioned about hypertension and hyperkalemia, around 12 to 13% what we are looking at. And yes, agree for both Abira as well as Darolutamide. But again, if you're looking at metachronous, I'd be looking at Daro, as more data is slightly there for Darolutamide. Abiraterone only for de novo.
Soumya?
Definitely, these are very useful data for our clinics. When we see somebody with a young patient with a high volume disease, then there is an option for us to offer him
What is the
triplet.
definition of young here?
So young means something like around 50 to 60, and the young means it is aggressive. So
Young
it is,
like Parikh sir and Rangaraju sir?
they are all young. They are much younger than me also. So the amount that they commit is a separate discussion.
Amol.
And another thing is that oligometastatic. So we should not forget that that is an emerging area. Oligometastatic prostate cancer does have a different approach, and we should look into that as well.
For me, the take-home message is probably for high volume disease, especially with visceral metastasis, for a fitter patient, we should offer triplet. Toxicity is a concern, and in our setup, I'll hands down prefer Abiraterone over Daro. I don't think so there is much of difference between the two.
Lalit sir?
I think in addition to whatever has been said, we need to take care of the side effects, comorbidities, and the quality of life issues also. And radiation may delay the urinary symptoms also in these patients and may alleviate part of that, maybe in metastatic settings.
Asif, please.
Sir, low volume disease doublets, high volume disease triplet. If patient is fit and relatively no comorbidities, then with Abiraterone acetate, and safety is a concern, then Darolutamide.
So key takeaway, so heterogeneous disease, so increasing alternatives, so different strategies. So how to select treatment, so still a long way to go. We need to work as a team for our patients. So biology remains the king, like Amol is the king of medical oncology for us. Thank you so much.
Group photo. Dr. Vinit Talwar, we are eagerly awaiting your expert comments on this. And all the experts, please be free to interject in between wherever necessary also. Thank you.
Thank you, sir. And as usual, Ghanshyam, it was a very lively discussion. So the points which come out of this discussion is, if we see one by one is whenever you put these patients on a triplet, first thing which comes to mind is the fitness. It has to be a fit patient, because most of these patients, rather all of them, are aged patients. Second, you have to keep the comorbidities in mind, because you have these two trials, and accordingly you have to suit which patient would benefit from which triplet combination. And there has been a lot of discussion between high volume, low volume, high risk, low risk. So when you see these three trials, I will include the Enzyme trial also, the low volume was the one which was the point of contention. There was no problem with the high volume or high risk. You can definitely give. Why there is a problem is, I just dug a bit deep. The problem is that in low volume, whether the patient is de novo or the patient is recurrent, both of them are clubbed under the same group. And when you do that, all of us know that there is a definite difference when it comes to the survival. So probably that is a caveat which has not been sorted out, and probably in other trials. Additional toxicity, yes. When you think of Abiraterone, as it has been discussed, hypertension is the commonest, then comes transaminitis, all of us face in our practice. So that definitely, and along with the fact that you have to give steroids, that is a problem. So after all this, once you give this triplet, when you put everything lock, stock and barrel and you give it in the first chance, and the patient, unfortunately progresses, what next? So that is another thing which is overbearing in mind, because after that you are not spoiled for choices. You have just, either you go for precision medicine or you give the leftovers. And finally, of course, the overall survival matters. If you give a singlet, you get about 30 months. If you give a doublet, you're going in about 45 to 50 months. You give triplet, you are going north of 60 months. So if you comply with all these criterion which are there, then probably if you put this patient, you get the best benefit. And unfortunately, we don't have any biomarker to suggest that which patient would actually benefit from this combination. And lastly, Indian data matters. We don't have our own data. I think we should collate and take out our data, because the number of Asians in this study are woefully inadequate. Thank you very much.